Hey, it's Stacy. If you are enjoying Tell Me What It's Like, please take a moment to go into your podcast app and leave a rating and review. It helps other people who might like this show find it. Thanks for your support. This is Tell Me What It's Like, a show about uncommon experience and the perspective it shapes. I'm Stacy Rain. Dr. Yemi Famuyiwa always knew that she wanted to be a doctor. During her time in medical school at Emory, she ended up falling in love with obstetric medicine and delivering babies. But she also loved the science behind how babies come into the world. So she took a keen interest in fertility medicine. Today, she helps hundreds of people a year work towards their goals of building a family. Dr. Famuyiwa, welcome to the show.
Thank you so much for having me.
I'm so glad you're here. I'm really excited about this conversation. I have had 3 babies, and
awesome.
Obviously I understood the miracle of birth and of how babies come into the world, but I don't know that I truly appreciated it until I was fortunate enough to be able to go through pregnancy and follow the weekly emails about how the babies grow and then to actually give birth. So I'm super curious about the very first time you helped bring a baby into the world.
As a delivery or as conceiving an embryo?
Oh, well, that's a perfect question from you. Let's cover both. Because I know even less about the embryo part.
Right. All right. So my first delivery of a baby was in medical school. So I was extremely fortunate and blessed to go to Emory, and they have a phenomenal program. And we would go down to Grady Memorial Hospital in downtown, which is an extremely busy hospital. With thousands of deliveries every single year. So as a student, you always got your fair share of deliveries. And I had a phenomenal intern that I happened to work with. So first night on call at OB, Grady's so funny. We used to have this, I don't know if it's like that anymore, but they would have this long hallway. And on one half of the hallway was where the laboring rooms were. And then the other half was where the delivery rooms were. And the interns and students walked in between in the triage section. If you decide they're, in labor enough to get admitted or they are not, and you send them back home. So you were in triage. And so you would triage people, work there all day, night, send them to delivery. And the third year residents and second year would monitor the labor. And when the patient's about to deliver, you would hear, "Delivery!" They'd run down the hallway. And they would always grab a student to come with them. And I remember the intern guiding me. First, of course, we've had our didactics. We know the mechanics. We've kind of role-played it a little bit. And they literally guided my hands through guiding that head out. And then the shoulders pop and then the whole body plops out. It's you can't, I hope I never get over it. It's just such a magical moment.
Yeah.
And in medical school, I got to do that about 24 times.
Wow. That's a lot.
Yeah, that's a lot for medical students.
It is magical. That was the word I was thinking of. That was the word that always came to me when I thought about a baby coming into the world.
It is.
It's new life. It's just
exactly.
It's almost indescribable to me, at least.
Yes.
What were you thinking that first time that you guided a baby?
Oh, I wasn't. I was just too excited. You're not really thinking that much. You're just like, wow, this is great. This is phenomenal.
Really?
The sheer joy of it. And you have to understand, as when you're an obstetrician, you go in because you're good with your hands and you like the surgical aspects of it. So, when you're doing a delivery, the whole world really narrows down to you, the baby, the mom, and everything else disappears. So you enter into this flow state. But it was a very magical, special moment, and it was great.
Yeah. I'm thinking about the long hallway and someone says delivery. Like sometimes there's not a lot of time, right?
Exactly. Well, yeah, sometimes we get patients who would come straight from the ambulance, and we don't even get to put them in the labor room before they're ready to drop the baby right then and there in the triage room.
Yeah.
Yeah.
I mean, it goes in sort of predictable stages, but you just sometimes never know, right? Like sometimes those
Yeah.
stages are boom, boom, boom.
Yeah. Yeah.
So you're in obstetrics, but then you discover fertility medicine and you sort of fall in love with that and the science. Can we talk about that that time in your life when you started to think, oh, maybe I want to go into fertility medicine?
Well, first and foremost, I'm a little bit of a nerd, so I'm one of those people that like to read textbooks cover to cover. I'm always reading, so that's intellectually stimulating and fascinating to me.
Right.
And really, I liked medicine on a very intellectual level. You know, I liked every aspect of medicine. And when we did our third year rotation, I wanted to be everything, every rotation that I did. So when I did internal medicine, I happened to work with a cardiologist, Dr. Nanette Wenger, who's like a phenomenal human being at Emory. And I think she's still there as one of the probably founding people in the cardiology field. So I wanted to be like her. I mean, she could make the heart sing. I really wanted to be like her. But the problem was, to get to cardiology, you had to go through internal medicine.
Okay.
I could not stand internal medicine. It was like eternal medicine. So, so when we have a problem, I can't get to this place because I got to walk through this to get here. So, well, yeah, we got to let that go. Loved pediatrics, but that could be a problem because I was one of those people that I would be crying over the babies and children who are in pain. I couldn't stand it. You know, it just brought me to tears to see babies in pain or little kids. So, you know, that doesn't work if your patients are trying to comfort you, if you're busy subbing over them, right? So I couldn't go into pediatrics. Love surgery a lot. But not enough to go through the grueling 5-6 years back then, and they had a pyramid system. So I went through all the rotations. I found radiology to be intellectually stimulating, but boring. I couldn't imagine sitting in a dark room reading films all day. It bored me to tears. I wanted to like it. Because of the lifestyle, and I took a lot of rotations in it, but it was just too boring. So at the end of the third year, since I liked so many things, I like psych, I didn't like eyeballs, so couldn't do ophthalmology. Yeah. So I said to myself, what do I really enjoy?
Yeah.
And the minute I asked that question, it was like a light bulb went kaboom. So easy. I had a roaring blast in my OBGYN rotation. Wouldn't trade it for the world. Even the GYN side, doing surgery with legends like Dr. Dan Thompson, you know, at Emory University, and, you know, the residents that would guide me through those. It was just an exciting, phenomenal growth phase of my life. And that, once I asked that critical question, I guess that's the key thing, is to ask the right question of yourself. It became so obvious what I was going to do. And that was it. That was it.
And so let's talk about, well, first I have a question about the surgeries. So you said you really like the surgeries as part of OB. What kind of surgeries are those? Yeah. The thing that pops into my head is C-section.
Hysterectomies. Okay. Not just C-sections, of course, but you do, hysterectomies, you're doing minor procedures, you're doing vaginal surgery. It's, surgery is a very fascinating thing for those of us that like it. Because I don't think I would be able to do that. I like the human body. To me, the human body is just one of the most phenomenal creations ever. I'm fascinated with the body from top to bottom. So, I was one of those in the anatomy lab where, we dissected to minutiae, and it was just opening avenues of new knowledge. With each layer that you opened up was a whole different story. You could read somebody's lifestyle based on what their body was in, right? Almost like doing a postmortem. The body can tell you so many things if you know what to look for. So I always like the human body. And surgeries, I love surgeries. Surgery. I love it. Again, it's one of those things you do where you can easily just go into a flow state, and, a nuclear bomb could go off and you wouldn't even know it because you're just focused in. So I can get into my flow states. I'm sure you've heard of flow states easily in an operating room.
Wow. Okay. And I'm thinking, as you say that you love the human body, you also seem to love very much even the very beginnings of the human body as a fertility medicine specialist. So let's talk about it. What is fertility medicine? What is it that you do day in and day out?
Right. So actually the full term is reproductive endocrinology and infertility. That's subspecialty. So it's not just eggs and sperm and babies. You have to look at the whole thing. Starts with the brain, how the brain is in exquisite control of your ovaries and your testes. And what are the things that can interrupt that control, such as your adrenal imbalance or your thyroid balance or your health state. Everything is just so delicately balanced. And understanding that nuance, going into that science, it's just, to me, it's like being a Sherlock Holmes of that field. There's so much to know, right? I mean, ultimately, you have to narrow down what you're trying to understand because new information keeps coming out every single time.
Yeah.
But, I hope I never get tired of this, but to me, just constantly learning. I mean, even today, I was just I read about, 2 articles a day plus other books. I read widely outside of medicine. So it is just something just tickles my intellectual curiosity and doesn't let me go.
Yeah, you're the type of doctor that everyone needs, the one that is just constantly reading. I don't know that many people would immediately jump to the brain and what it has to do with fertility.
Oh, yeah.
So let's talk about that a little bit. That is, it's because the hormones all have to do with the brain, right?
Well, think of your brain. It has, when you go to an orchestra, you ever go to an orchestra? Yeah. And you see the conductor conducting the whole orchestra, and then you have the flute on this side, and then you have the trombones, and then you have, you have the vocals on that side, or you may have a piano, and the conductor has to call each section of the orchestra in at different times of the music. It can, raise up the crescendo, bring it back down. That's what your brain does.
That's amazing. Yeah, and all the steps of fertility, that's what your brain is doing.
That's what your brain does.
The human body really is amazing.
It's fascinating. Look, we could sit here and talk about it forever.
Yeah, that needs to be, our second episode together because it really is truly amazing. There's so much.
Yeah.
And there's still so much we don't even know.
Yes.
Right?
It's incredible the amount of information that is just coming to the front. Because, everything we know serves as a foundation for what we're going to see in the future. So the more understanding we get, the more techniques we have to conduct investigation. That gives us the tools that we can go a little deeper. So some of the things we know now, we could not know back then because the tools were not available, right? Yeah. Now we know more. And the more you know, for instance, when the whole genome, the human genome was sequenced back in the 90s and so, that just exploded and revolutionized the field of genomics and genetics, right? So now we can go one step further and now look at the whole population level, right? By studying, bacteria, we've heard about microbiomes and stuff like that. We didn't have all that information back then. So now we're just seeing, it's like a whole universe of knowledge is just exploding in that field. So that's the way medicine goes. You start with a little, and somebody else builds on top, and somebody else builds on top, and you create new techniques that helps you study better. And there's, to me, there's no end to it.
Yeah. It makes me curious what sort of the landscape of fertility medicine is right now. Are there lots of leaps being made currently?
Absolutely. All the time.
Really?
All the time. In the field of genetics, in being able to use fertility to help patients that may have debilitating inherited diseases that they may not necessarily want to pass on to their children, in being able to figure out, what could affect the sperm. How do you use artificial intelligence to pick out the best sperm possible that has fewer damage in the DNA, right? We didn't have those tools back then. Now we have it. Now we have AI that's also hopefully helping us select for eggs that may have a higher reproductive potential than, some other techniques where in the past we used to use just looking at, we would look at it and say, oh yeah, that one looks pretty. Or, you're grading an embryo and you go, oh yeah, this embryo looks like, oh yeah, that's pretty. Yeah, now we have tools that can help us pick them out a little better. We didn't have those tools back in the day, right?
Yeah.
So each discovery helps us to uncover more things.
That I hadn't thought about using AI yet, but that is fascinating. That's a really fascinating use of AI for this selection.
I mean, AI is a tool. You just have to learn how to use it.
That's fascinating. Let's back up. So one thing that you recently wrote a book, and one thing that I really enjoyed about your book is your focus on culture and fertility.
Quest for fertility.
So I thought the quest for fertility. So I wanted to talk about first with you this idea of culture and fertility and have you talk about that. I know you grew up in Nigeria and you said that your culture influenced your thoughts on fertility.
Right.
So can you tell me a little bit more about that?
So because, I think so in America, but not as much. But and then let's grasp it for a second. Infertility is now 1 in 5 people, 1 in 6 people worldwide, right? So
worldwide.
If it's worldwide, that means the vast majority of infertile people are not necessarily in the US, correct?
Yeah.
So there are a lot of people suffering. Now, in certain society that are paternalistic societies, there's a lot of expectation, right? When you get married, you're not marrying a person, you're marrying the family. And you're marrying the village, you're marrying the clan, you live your tribe, you go marry you into a tribe, you're marrying into, right? You're not marrying one person. So there's a lot of pressure societally, culturally, to continue what they think they brought you into this clan, into this family to do, right?
Well,
your job is to reproduce and to, promulgate the next generation. So, and they're, families that could be extremely wealthy and powerful, and they will literally decide if their child should marry this person because they say, well, wait a minute, she's not able to produce, she's barren, and she can be cast out, right? So there is a lot of pressure. And then, there's also the stigma. That word barren, so stigmatizing. There's a lot of hidden shame where people feel devalued. They're not even considered worthy of being called a human being because they have their whole identity has been reduced to that of just a childbearer. And if they're not able to fulfill it, they are castigated, ostracized, stigmatized.
Goodness. That is, and I think that's something that, at least here in the U.S., women have pushed back against in the last, 60 years?
Correct.
Would you say that's true for our culture?
I think so. In America, within certain, also America's a melting pot culturally.
Right.
So in this microcosms, you might still have some of that, right?
Yeah.
But maybe not in the Western thinking per se, but it's still, because, some cultures come in here and they don't necessarily divest themselves of their cultural background, so they hold on to it. And so you still see some of that stigma, So I have patients that come to see me who are multicultural from all over the parts of the world, or even if they live here, different backgrounds, and they'll pull me aside and whisper to me, okay, this is what's going on, please help me, blah, 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 So yes, in the broader society, not as much stigma, but in certain isolated pockets, there are women who are suffering in silence.
Right.
And men too, actually.
Okay. Tell me more about that.
Well, it's so funny. Men sometimes can feel emasculinated when they know that they have issues with producing sperm. And that may not necessarily even be cultural. Yeah, in some culture, it may be deeper. But it goes against their whole being, that identity of masculinity, right? And that can be a source of depression, a source of shame. And sometimes they find it hard to reach out and talk about it and ask for help.
And is because of your knowledge of the sort of cultural aspects around fertility, that's something that you bring into your daily practice?
All the time.
How do you do that?
So I'm someone who's naturally interested in people, right? I just love talking to people. I'm nosy. Where are you from? And all that. I just enjoy them. So, I can't tell you numerous times where I've had young couples come in from Nigeria, and I could see the tension between them. I could see it. And many times, that tension breaks out where they have severe difficulties in their marriages. I may sometimes recommend counseling, but some of these cultural background, they don't really believe in counseling. So then I would treat them, from that perspective, and I'll try to explain to the husband per se, this is what your wife is going through. This is why she's this way, maybe try to get a little bit more encouragement and support on his end. And then try to point out to the wife as well that, okay, maybe you need to meet him halfway. This is how he's trying to support you. But then we talk about how it may affect them in their families. And I do encourage them that, look, at the end of the day, when you close your door at night, it's between you and your partner, not between you and grandma, auntie, mom, societal auntie, try to keep it in that. But there can be a lot of pressure, because some of these families are nosy. They'll go, well, what are you guys doing anyway? Well, what are you waiting for? Why are you not pregnant?
Yeah. And even if it's not spoken directly, I think that can be a source of stress for a lot of couples.
Yes, it's just enormously unfair.
Yeah.
And very, very difficult.
Right. Whether they want to have, whether they've decided to have children, whether they've decided to wait for whatever their, future looks like to them. Those sort of unspoken questions can be really challenging.
But I think with support, with helping them, when you show that you hear them, then they're ready to open up. Then they're ready to listen to you in turn, right? Because you can't do this without their cooperation. I always tell patients, this is a teamwork between all of us, right? We have to work as a team. And they won't necessarily cooperate with you if they don't feel that you've heard them and that you care.
And that you understand them. You understand where they're
Yes.
coming from. That's huge.
Exactly.
That's
Yeah.
really big.
Mm-hmm.
You mentioned that infertility is on the rise
Yes.
worldwide.
Worldwide.
Why? Do we know why that is?
I think it's multifactorial. I think there have been lots of articles coming out about this. Is it the food that we're eating?
Mhm.
Is it the chemicals we're exposed to? Is it, yes, some people may be delaying childbearing.
Mhm.
And also, I think a lot of people are not significantly knowledgeable about the limitations of their own biology.
Correct.
Right.
Yeah.
I can't tell you. And one of the stories in my book, you see in there, I had several professionals, PhD doctors, who, from an African background, who were busy chasing that goal that you're supposed to. You didn't come. When I came to America, I always tell my classmates, I didn't cross the Atlantic Ocean to fool around.
Yeah.
If I wanted to fool around, I could do that back in Nigeria. I came here on a mission.
Yeah.
So they come in here on a mission, your tunnel vision, you're focused. And some of them, it's even worse for them because maybe they're the firstborn and they're women. And when they succeed, the expectation is that they may help their siblings back home. So then they're under pressure to work and save and send the money. So by the time they slow down to even think about themselves,
Yeah.
all of a sudden, they're over 40. All of a sudden, their reserve is down.
Mm-hmm.
All of a sudden, their egg quality is no longer as good.
Yeah, we have this thought that we can put it off and it'll all be fine because women have babies until they're,
Right.
And
Or to think that, well, I'm still having my period, and my grandmother had her last child when she was 49. What are you talking about? You get all those things all the time, but, well, maybe she did in her era, but it's not so now.
Mm-hmm. So is part of it that people are putting off their childbearing
Not
time?
all of it, because if you look into that, it's not all of it, because you look at people who have tried, who've started early, who still have that gap. So something is still happening on a biological level.
And we don't
we cannot
know.
blame it on just,
Putting things off.
delayed childbearing. But there is, for instance, a decline in sperm parameters, right? Men are no longer as fertile as their grandfathers were. There's a decline in the number in sperm concentration over time, right? So, and then you might have women who, for whatever reason, lose their eggs much more rapidly than the average person would, and they go into premature ovarian. We used to call it premature ovarian failure, but that's not the term now. It's called premature ovarian insufficiency. So that's still happening, right? So there are so many reasons that are part of the reason why infertility is on the rise.
And we don't necessarily know yet the causes. That's a big mystery.
Mm-hmm.
Fascinating.
Mm-hmm.
We know a lot about how babies are made.
Mm-hmm.
You talk about that in your book. Like I said early on, that was one of the things that the fascinating that you call it an orchestra, and it really is. All the things have to line up. Everything has to be just perfect for a baby to be conceived. It's sort of it's a mystery, how we have so many babies when everything has to be basically perfect.
Mm-hmm.
Is that pretty accurate?
Yeah, absolutely.
It's timing, and you talked about just what's happening inside a woman's body to guide the sperm to the egg, and it's
right.
sort of the human body is really really incredible when you look at the orchestra, as you call it. I thought that was a great term. So we know a lot. We know a lot about how things work, but we also, it sounds like there's a lot that we don't know, including, with the rise in infertility, what's actually causing it. That must be a huge...
Yeah, we don't know everything, but we know that some things can affect. For instance, if you are exposed to endocrine disrupting chemicals, toxins in your environment.
Yeah.
And also the food supply. We now know that patients can have toxins from leftover mold in food supply.
Really?
All those things can affect the egg and the sperm quality.
Making it harder to conceive.
Absolutely. Absolutely.
The other thing that I thought was fascinating that I learned from your book is how a woman's body and what it does helps with the selection of making sure that strong genes carry forward, right? So that that the strongest of the sperm can actually make it to the egg.
Right. How the sperm journeys up through the reproductive tract. Isn't that something?
Yeah.
You have to think of it. Imagine they're in a Formula F1 race, it's like Max Verstappen racing Lewis Hamilton, and then Lando Norris comes right through and whoa, what
right. And how, I guess I just never really spent much time thinking about it, but how the body makes sure that, it can create a viable pregnancy. And part of that happens just by sort of making it a little bit difficult to get where it's got to go. Swimming upstream. So
there's so many. It's that's just another. I call it the race of life. Getting the sperm up the reproductive tract, having the egg being released, and they have to be present at the same time in the fallopian tube. So many things have to be in place correctly, right?
Yeah.
So it's incredible. Yeah.
Yeah. So you have patients come to your practice. What are some of the first things that you do with them? What happens in fertility or reproductive medicine?
So the first thing in any reproductive field is to get a thorough history. You want to get a comprehensive medical history and a good physical exam. Those are always the first elements of fertility care. You really want to get that medical history down, talk to the patient. I can't emphasize that enough. And then you do a thorough physical exam because there are certain things you can pick up on the exam. If the patient has acanthosis nigricans, that's this darkening around the neck. Do they have insulin resistance? Do they have adiposity that makes you suspect, Cushing syndrome? Do they have hirsutism and facial acne that makes you suspect polycystic ovary syndrome, or we now call it polyendocrine metabolic ovarian syndrome. So there are so many clues if you learn the body. You got to be a little Sherlock Holmes of investigating. Yeah. So you do your thorough history physical. Then you do an ultrasound where you're looking at how many follicles are in the ovary at any one time, because it gives you an idea how easy or not it will be to collect eggs from that person. Right? So those are just the preliminary part. Then you can do other additional complicated tests, but you got to start with the basics first.
Right. And you'll end up going through with these different patients. There'll be different, I guess, prescriptions, so to speak, for each of them. Some of them may be there for egg retrieval. Some of them may be there for IVF. There's a lot of different things that you're doing. But unfortunately, part of your job also is walking with people in grief quite a bit. Tell me how you approach this idea of moving through grief with your patients.
So grief comes into infertility when, sometimes I'll have someone who struggled to get pregnant for a long time, and they get pregnant and they lose the pregnancy, right? That's devastating. Or, they're doing treatment after treatment and, they can't wait to check the, pregnancy test results and it's negative. Or they get pregnant and they're super, super excited. They get pregnant and then it results in a miscarriage. So it's, in medicine, we call it ambiguous loss, because it's the kind of grief that is not really, there's no end to it, right? Because, if you, especially with infertility, it's not like you have a body to weep over. There's no physical death per se. So it's that ongoing trauma of, not being able to conceive. So it's that ongoing thing that can be very devastating for patients. Some patients may have, they may have depression with it,
right,
from this loss. This is a name for it. It's an ambiguous loss. It's a grief that I talk about in my book. It was actually, there's a whole study on it, where the grief is never ending. It's just an ongoing painful episode of life.
Right. It makes me think of miscarriages. And I know that up until fairly recently, they were not talked about, which could make, and I'm sure this still happens, especially for people who are experiencing infertility. The not talking about it can be, make it even more painful. And I think a lot of it is because people don't really understand it. And you mentioned this in your book. One of the lines jumped out to me because I experienced a miscarriage, at one point in my life. And it was, I want to say, surprisingly devastating in a way that I mean, it was one of the deepest, it was a very deep grief. And I guess I was surprised by it. And so a line from your book, really, it jumped out at me because it makes me think about other things that people say, and they don't mean them to be harmful. They're trying to help, but sometimes
they don't know
hurt.
how. Yeah, they don't know how.
Things like, oh, well, especially in the case of miscarriage, well, it wasn't a baby, or
that is very, very hurtful.
Yeah, but to that person, it was. As soon as you find out you're pregnant, it's like, oh
yes.
Even in early miscarriages, I should say that it's exciting. You think of the future, or you've looked at the date when the baby's going to be born. You've projected a future that then suddenly is no more.
And also, probably once in a while, you look and say, "Oh no, if I had my child, he or she would be this year's old now, or he or she might be the next astronaut," or that won't go away.
Yeah, it's a strange grief, I would say, that I'm sure you have to walk through that with many of your patients.
Yeah. Had a pregnancy loss myself, so.
I know. You mentioned that, that you yourself have experienced the things that some of your patients have. How does that, how do you think that changes your practice?
I mean, my tangle with the medical field as a patient started when I was in high school. Or actually before that, when my father got sick, and then my mother had to have surgery and I had to care for them. I have always been this way, so that I don't know that I would say it affects me, but I think I can see, I try to step back a little bit and try to see it from their shoes, right? I really do. I try to step back. And sometimes you get so busy, it's hard to do, but you got to take a step back a little bit and say, wow, from their lens, from their point of view, if I were walking in their shoes, what this would be like, right? And sometimes it helps you choose your words when you're trying to talk to patients.
Well, there's so much science that goes into what you do.
Yeah.
That I would think there's many doctors that can zero in on the scientific piece, and maybe that makes it harder for them. Like, I don't know this for sure, but I mean, I would think if you're really focused on the science and what's happening in the body and this, that, and the other, you may forget to focus on the emotional piece.
So then to that, I say it goes down to their training. So I was extremely fortunate throughout my training, both in medical school, in residency. I had mentors that modeled for me what being a compassionate provider should look like. So I've always had that, even from when I was a kid, and caring for those I loved and seeing their pain and how to help them, and then going into institutions that made me so proud to go into this field. I've had exemplary attendings and residents when I was a student. I'm forever in gratitude and in awe, and and just in absolute awe of them. One of them is like the dean of a medical school now. It's just a phenomenal woman. And then in residency, I had, the old school guys who were extremely gentlemen. Who would, talk me through, Yemi, this is how we do this. You respect the tissue. So it's not just you learning the field, but you learning to be. I think that what stood out in my training.
Yeah. That's a great point. What is it that you, after all these years of practicing reproductive medicine and walking with families through, or walking with people through working towards building their own families, what do you wish that people better understood?
So, and this is part of the reasons I wrote the book, to have a little bit of a knowledge about what's in your body. And you can't change your biology. We know that. But you can certainly harm it.
Yeah.
So you want to learn the things that you want to do to avoid making things worse. And I think that if I could help spread that knowledge, my book would have done its job.
Oh, that's wonderful. My last question for you is a big one because of the type of work you do.
Yeah.
Because you focus on helping bring new life into the world.
Right.
How has this line of work and working with all of these different people and building their own families, has it made you look at life differently?
I enjoy life. I enjoy seeing patients going through the steps and then coming out of it. I have patients who reach out to me whose kids are now in college or graduated that I helped. So being part of that, being able to see that and having them share that part of their life with me, not just coming to see me as a doctor and, oh yeah, we got our baby out of here, but just reaching back over the years is probably one of the most fulfilling things for me. And I feel fulfilled, I feel blessed, and I don't take life for granted at all.
Well, thank you so much for sharing your wisdom with me and for joining me on this show. I sincerely appreciate it.
Thank you so much for having me.
Thanks to Dr. Famuyiwa for being on this show to talk about the science and emotions behind fertility. If you like this show, please be sure to follow it in your podcast app, and please go leave a rating and review. It matters and it helps. I'm Stacey Rain. Thanks for listening.